Thank you so much for joining me for our lecture on lower extremity venous ultrasounds. We'll go ahead and jump right in here. Our objectives for today are to describe the components of the lower extremity venous system. This should be a review in that we just took a look at our anatomy of all of our vascular systems just a couple weeks ago, but we can briefly review the lower extremity system, as I find having a lot of confidence in your knowledge of anatomy makes these a tremendously more efficient and easier. We're also going to define the normal image and the Doppler characteristics of the venous system, identify the image characteristics consistent with acute or chronic thrombus, describe Doppler waveform characteristics associated with various pathologies, and list the risk factors associated with the formation of a deep vein thrombosis, or DVT. So DVT diagnosis is very tech dependent. Your exam is only as good as the tech that's completing it. Not to say that it's completely tech dependent, it can be also very much equipment dependent as well as patient dependent, but ultimately the only thing that's really under our control is how confident and knowledgeable we are in our skills. A deep vein thrombosis is most appropriately identified using duplex ultrasound, meaning that we're going to utilize B-mode imaging along with color imaging and our spectral Doppler to get the full picture of the situation. This allows us to diagnose a DVT, localize it, and determine the age, which can help guide treatment. It also determines the relative risk of thromboembolism, as we know that some thrombi are more likely to embolize than others and therefore are at higher risk to the patient. So it allows us to get a better picture of what to expect from the thrombus moving forward. And it again allows us to evaluate the competency of contained valves to ensure that they are still functioning, preventing retrograde flow of the venous system. If we look at the anatomy of the lower extremity, we can break it down into deep veins and superficial veins. Now, the biggest, aside from their name, which kind of describes a little bit about where you expect to find these, the probability that you will create an embolism from one of these systems is going to be very different. So with our deep veins, that's our main conduit for blood return. That's going to include veins like our popliteal, our superficial femoral, our common femoral, and things like that. So most of our blood is really traveling through the deep veins. Now, our deep veins are not assisted with a pump, and so we know our arterial system is completely controlled by our heart, which acts as a pump. Now, our venous system, on the other hand, does not have a pump pushing that venous blood back up to the heart. And so we're really reliant on our muscles to act as a pump. So flexion of the calf muscles of the muscles of your thigh, all of that helps project that blood superiorly in the body so it can reach back up to our heart. And then the valves are going to prevent it from backflow. Now, because the deep vein system handles most of the volume of our venous system, they're going to be a much larger veins, and therefore larger veins equal usually larger thrombus. So these veins, because of their size and because they are often compressed by muscles acting as a pump, they're more likely to throw a clot, as one might say, than our superficial system. So these are the veins that we're really going to concentrate on when we're doing a lower extremity DVT study. Now, our superficial veins, while they might not be as much of interest in this study as our deep veins, they also have a very important role. And one of the most important roles of our superficial venous system is to keep veins and venous blood closer to the periphery or closer to our skin layer. And that allows for temperature regulation. So obviously, the more internal veins of the deep system are going to maintain warmer levels, whereas the superficial system are going to be a little bit cooler typically because our skin is able to emit that heat and cool them down. And so what we really want to know is that our superficial and our deep venous systems are communicating, and that really is going to help regulate our body temperature. And it is important to note that usually if there is a superficial venous DVT, usually it's going to begin at the communication between the deep and the superficial system. So another piece of our lower venous anatomy is our perforators. These are the veins that are going to connect those superficial to the deep venous system. And so perfs or perforators are the ones that make that connection to allow the combining of those two blood systems to help maintain that pressure. These have one-way valves to move blood into our deep system, but if they have poor functioning, it can cause stasis, leading to edema and venous ulceration. What happens with venous ulceration is if your arterial system is allowing too much fluid to come out of your artery, that your venous system is not effectively reabsorbing, then the proteins from that fluid can begin to break down skin components and lead to venous ulceration. So just beware that your perforators, if they are not allowing blood flow, can lead to that sort of edema, which then can progress on to venous ulceration. Okay, epidemiology. So as you know, if you're working in ultrasound, the numbers of DVT studies that are ordered are extremely high. And part of this comes down to the epidemiology of this particular process. So there's about 500,000 cases of DVT each year, and they estimate that there are about 50% of those go unrecognized. So obviously, if they're unrecognized, they're untreated, and the patient's at higher risk for pulmonary embolism and death. Out of those 500,000, at least 200,000 of fatal PEs occur each year in the United States. Now, if you have a DVT and fortunately does not result in a pulmonary embolism, there are other things that can happen. Some patients may experience post-thrombotic syndrome, and this is where after a DVT has progressed and even possibly resolved, a patient may be left with ongoing symptoms. Some of those signs and symptoms are really due to chronic venous insufficiency. So once that vein is damaged with a DVT, then it can cause inability to return to that normal circulatory environment that they once had. So some of the symptoms they may have because of this insufficiency would be leg pain. The blood is kind of pooling down in the leg, and it can cause edema, pain, a feeling of heaviness. The stretching can cause itching, tingling, and cramping. And you also might see some darkening or changes of the skin color of the leg, and even venous ulcers if those proteins in that edema really begin to break down the tissues. So obviously this is a big problem, so we do need to be very adept at being able to identify these and helping these patients. Okay, the pathophysiology of a deep venous thrombosis. So we can use something called Virchow's triad. And Virchow's triad really describes a patient's risk of forming a clot. So some of these things, the triad would indicate 3 items. So these 3 items are going to put patients at higher risk. Number 1 would be venous stasis. So that would be a lack of mobility. The muscle pumps are not being activated to push that venous blood back up to the heart. And when we have blood sitting in vessels for long times, not really moving through, they're more likely to begin to organize and produce a thrombus. And so venous stasis can be a big indicator or a big risk factor for developing a DVT. So this is why you see patients that have been traveling for long periods of time, on an airplane for a long period of time. Those things that prevent mobility put you at higher risk because of the stasis. Next would be vessel wall injury. So this could be from a traumatic event, or it could be an iatrogenic result. So an iatrogenic issue is an issue that occurs as an unintended consequence of another medical procedure. So if maybe the patient had surgery, the vein was not supposed to be involved, but the surgeon nicked it or something like that, that would be considered an iatrogenic injury. However, other times it can be a vessel wall injury just from normal trauma. So that's the secondary part of Virchow's triad. And then thirdly is patients being at a hypercoagulable state. So if a patient has various types of cancers, or they're on certain medications that increase the development of thrombus, or on birth control pills or hormone replacement therapies, all of those, along with certain genetic factors that make patients more probable of to coagulate, any of those would put the patient at higher risk. So Virchow's triad, in quick review, are the 3 items that place a patient at higher risk of developing a thrombus: venous stasis, vessel wall injury, and hypercoagulability. Now, when we start to form a blood clot, that thrombus formation is determined by the imbalance of clotting factors, coagulation inhibitors, and the fibrinolytic system. So it's really that fibrinolytic system that goes in and breaks down clots once we've built them. And if we are out of balance here, we're developing clots but not really stopping their production with the inhibitors or not breaking them down. And this is where the issues arrive. They also often can originate around valve cusps, and this is really due to stagnicity of the blood in that area. So we know if we have, let's say we have a big calf muscle contraction and it causes blood to move forward in that vein, and then the calf muscle reacts, that blood is going to settle down into the valve cusps. Now, the next time that blood gets pushed forward, some of that blood in the valve cusps are going to be collected in that area and not continue. So my valve might fly open like this, protect a bit of blood in here, and then close again. And that produces stagnicity of that blood and really goes towards Virchow's triad's first element, which would be venous stasis. Okay, so risk factors for DVT, these really contribute mostly to Virchow's triad as well. A patient that is at advanced age, usually you lose some mobility with age, so that puts you in more of a static, that puts you more likely to have static venous flow. It also can be accompanied by things like atrial fibrillation and different things like that that also increase your probability of blood clot formation. Surgery or trauma, that really correlates with the second item on Virchow's triad, where it would be disruption of the vessel wall. Immobilization, again, goes along with stasis. Past history of DVT would indicate that the patient may exist in a hypercoagulable state, so that would go to item 3 on our Virchow's triad. Coagulation disorders, like I mentioned, could be congenital or genetic, or it could be acquired through drugs and hormone replacement and things like that. So again, that's going to go with item 3 on Virchow's triad. Malignancy can put us into a hypercoagulable state. So again, that's item 3. Septicemia, that would be infection in the blood flow, which would put us in hypercoagulable states, same as birth control, same as hormone replacement therapy, pregnancy, and obesity. We have to remember that fat or adipose tissue produces more estrogen. So obesity can really act almost like taking additional hormone replacements. A stroke would indicate possibility or likelihood that the patient does already have a hypercoagulable system. Congestive heart failure prevents the movement of that venous blood flow into the heart. That would cause stasis. Long distance travel would cause stasis. Inflammatory bowel disease can affect our proteins in different levels, and that can lead to hypercoagulability, and then varicose veins would lead to stasis. So really, when you look at all of these risk factors, rather than memorizing this entire table, really anything that comes up, you just need to ask yourself, would this be associated with one of the items on Virchow's triad? And if it is, that would indicate that the patient is more likely then to develop a DVT. Okay, signs and symptoms of a DVT. The DVT causes venous obstruction. When we have venous obstruction, we're not returning the blood flow to our heart as efficiently as we should. Therefore, our arterial system is going to keep pumping in blood to that lower extremity, and yet because of a blockage or a DVT, it's not going to be able to get that blood back out and remain homeostasis. So most of the time, you're going to have some signs and symptoms with a DVT, although it is possible for them to be asymptomatic. When we do see signs or symptoms, most of the things that patients will complain of is extremity pain and tenderness, swelling, venous distension, discoloration. You'll see a redness to the leg, and palpable cord. Now, all of these things, the pain, the swelling, the distension, the discoloration, all of that is because there's blood accumulating in the leg that should be being picked up by the venous system and returned to the heart, but isn't. So it's leading to all these things. Now, a palpable cord is usually from more of an acute type of, more of a chronic type of thrombus that has really become hardened, and you can actually feel that like a frozen hose in the patient's leg. Signs and symptoms of PE. So our biggest concerns with our DVTs are that they are going to break off part of that thrombus, have that thrombus go through the heart, and then lodge into the lungs. So our symptoms with our PE must be considered in addition to DVT symptoms. You want to make sure that that patient is not having tachypnea, so that would be fast breathing, chest pain, or tachycardia, fast heart rate. In addition, we can do some clinical markers that will aid in diagnosis or in the risk-benefit decision when physicians are ordering a DVT or considering to order a DVT. One of the things that they can review is something called Wells criteria, which we're going to go over on the next slide. The other is a D-dimer. So D-dimer is a serum test that can measure the breakdown of fibrin, and the breakdown of fibrin tends to be elevated in DVT. So with an elevated D-dimer, that indicates a risk of DVT. However, it's very non-specific, so it can lead to a lot of unfounded concern. Both of these have poor sensitivity and specificity, and so this might be part of the reason why we get so many DVT studies, because these other factors that they're using to rule DVT out are really not that effective. Okay, when we go to prepare the patient for the exam, we need to make sure that we're explaining the procedure and obtaining history and labs. So oftentimes your patient won't know what they're there for, so make sure that you're clear in telling them what you're going to be doing. This is also kind of an intimate procedure. Your patients usually need to be down to their underwear, possibly even remove underwear depending on the access that their particular underwear provides you to the groin. So make sure that you're communicating well with the patient. Another great tip is that you want to put your patient into the reverse Trendelenburg position, so their heads would be well elevated above their feet. And what this does is it kind of allows some of the venous blood to pool in the legs, in the veins, and that will actually make your scanning the exam easier because the veins will be more dilated. Then it's going to be important that you evaluate the patient's history and their labs. So you want to look for anything that is related to Virchow's triad. Have they been traveling? Are they on blood thinners? Have they ever had a stroke, a heart attack? Looking at, have they had recent surgery? Looking at all of those, kind of developing a clinical picture in your mind and recording that for the radiologist to review. As far as your lab results go, if they're available, you'd want to evaluate the D-dimer because while it's not a very specific or accurate indicator, it does have some relevance, so we should be looking at that. Once you get the patient's thorough history, you want to make sure to get them changed and comfortable on the table, put them in that reverse Trendelenburg position, and get the veins starting to fill. And then you are going to, it's useful to take a moment to demonstrate what a Valsalva is and how you're going to be augmenting the patient's leg. You'll realize that if you forget to describe this in advance, assume the patient would know, it is going to end up adding a lot of time and possibly frustration to your exam. So providing this information, explanations, can be very helpful to do before you even start the exam. Another thing that can be really useful when you're doing this and you say have a patient that has one leg much more swollen than the other, you can actually do thigh, knee, calf, and ankle measurements, comparing the affected side to the contralateral side, just to demonstrate for the physician exactly how much swelling there is. Then once you're ready to begin the exam, you can keep usually the unaffected or the leg you're not scanning at the moment covered with a warm blanket to keep the patient comfortable. And then when you're ready to get going, you're going to want to bend the patient at the knee and drop their knee away from them, exposing that groin crease, because that's where you're going to be starting the exam. So for the exam, you're going to want to do most of the exam that you can with a high frequency linear transducer, usually in the range of 5 to 10. However, some of these vessels can dive very deep, or some patients can have a lot of soft tissue covering the vessels. And when that's the case, don't be afraid to switch to a lower frequency linear, or even to a curvilinear. Curvilinears can be especially effective when you're looking at the deeper veins of the calf, because of those calf muscles can be difficult to penetrate. Or if you find a clot in, say, the common femoral, and you need to go up into the pelvis to assess the external iliac or the common iliac, then of course you'd want to switch to a curvilinear. Okay, so when we get down to the protocol that we're going to do, I like to start these in transverse. So you begin right at the crease of the groin in transverse, and you're going to want to find the common femoral vein. So if you're seeing it bifurcate, or if you're seeing the superficial and the profunda, you're too low. You need to come up and make sure you're in the common femoral vein just after your superficial femoral and your profunda or deep femoral have anastomose to create that. And you'll want to take a look at that common femoral vein, make sure that you don't see any internal echoes, and then compress through that vein. And you'll want to record or take an image demonstrating in dual screen the common femoral vein with the common femoral artery with no compression, and then with compression showing that common femoral vein disappearing. And once you've completed that, you want to then move on, and you will go down only about a couple centimeters typically. Continue compressing, releasing pressure, moving your hand downward, down the leg about a centimeter or two, and compress again. Once you see where you have, you see this bifurcation or the two separate vessels of the superficial femoral and the deep femoral vein, or deep femoral is also known as profunda. Once you see those, you're going to want to take an image at that level. So here's an example of a dual screen. You see the superficial femoral, the deep femoral artery, and then you see the superficial femoral vein, deep femoral vein. If you don't know for sure off the top of your head which one's artery and which one's vein, you'll recognize that very soon as you start the compression. As soon as you compress, you should see the SFV and profunda disappear, and your SFA and deep or profunda artery will stay open. Now, if you're having a hard time telling if you've compressed enough, maybe one of your veins is not totally collapsing. If you're starting to distort the artery like we are here, see how it's a little more flattened than over here, that would indicate that that's adequate compression, that if there's no thrombus, really the vein should compress at that point. Okay, so right here in transverse, we evaluated our common femoral vein. We evaluated it without and with compression. We moved slightly down, and we evaluated our superficial femoral vein and our deep femoral vein just prior to their confluence without compression and then with compression. Now we're going to continue down following that superficial femoral vein. At this point, our deep femoral vein can get very difficult to evaluate because of the depth in the thigh, and it is not considered a high-risk vein for embolus. And so usually if you've evaluated it right there, right before it anastomosis with the superficial femoral, that's going to be the extent of your evaluation of the profunda. However, the superficial femoral vein is very different. So now we're going to, what you just accomplished was the transverse imaging of the proximal superficial femoral. At this point, you're going to want to work your way down the leg in transverse, compressing every 2 to 3 centimeters, following that superficial femoral vein into about the mid-thigh. When you get to the mid-thigh, that should be the mid vein. So at this point, you would obtain more images with dual screen, showing the superficial femoral vein dilated and with compression. Then you'll continue compressing every 2 to 3 centimeters down until you get to where the superficial almost begins to lunge into the patient's popliteal area. At that point, you want to take your distal superficial femoral images. So you would take superficial femoral vein without compression, with compression, and demonstrate that it is compressible. At this point, sometimes it's really helpful to actually then roll your patient away to expose the popliteal area of their effective side. So if your patient lays with their knees slightly bent in a decubitus position, exposing their popliteal area to you, this can increase the ease in which you can evaluate that area. So once you get into the popliteal, once you the superficial femoral vein dives through that abductor canal and becomes very hard to scan, move to the back of the leg, and really it's at that point that it becomes the popliteal. The popliteal is pretty superficial, and you are going to want to then compress the popliteal every 2 to 3 centimeters and take one representative image with no compression and with compression of the popliteal as you work your way through the back of the knee. Once you get just inferior to the knee joint, you will find another vein dumping into the popliteal. That vein, the first vein that you see do that, is going to be your anterior tibial vein. This again is one that we don't typically follow to its at length because of its relative low risk. However, it's nice to take representative images and evaluate it at the confluence. So just before the anterior tibial dumps into the popliteal, as you see occurring right here, you would want to compress and take your images with and without compression in dual screen right about at this level. And at that point, you can usually move on from the anterior tibial. Now, if we look at the anatomy that we're into now, as soon as that anterior tibial has dumped in, and once we're distal to that, then we call this the tibio-peroneal trunk. And we call that because this trunk is really made by the confluence of the posterior tibial veins and the peroneal. So therefore, it's recognized as a tibio-peroneal trunk. So you'll want to follow compressing every 2 or 3 centimeters through that tibio-peroneal trunk, which really will only take a couple compressions. And then you should see the separation of your posterior tibials from your peroneals. Now with this, we do want to evaluate our peroneal and our posterior tibials all the way down. So and it can be very challenging. It's usually the peroneals that one might need to switch to a curvilinear. So you'll want to either all in one screen. If you can keep them all in one screen, you can evaluate them with and without compression together, proximal, mid, and distal. If that's impossible, you can image your posterior tibs with your linear and then change to a curvilinear and get your peroneals in those 3 areas. And that will really take you through all the transverse images you need to get of the venous system in your lower extremity. Now, at this point, if no thrombus was identified, you're going to want to then follow all the veins from that ankle back up. So we're going to go backwards now, evaluating all the veins in long, in B mode, in long with color, in long with spectral, and then in long with spectral utilizing augmentation and Valsalva. So at this point, you can go to long and you'll want to start right at the medial malleolus. And that's where you're going to identify the posterior tibial veins, as you can see right here. These would be our posterior tibial veins here and here, and they're followed by posterior tibial arteries, of course. So here's our posterior tibial veins. And in this very fortunate picture, you can actually pick up the perineal veins as well. So these are going to be bifid sets of veins. So you'll want to evaluate them without color, just looking for any low-level echoes. Then you're going to want to add that color on and make sure that they're open. It's occasionally you'll have to augment just to get these to fill because their flow is so slow. It can be difficult to identify it without augmenting. So you take it without the color, with the color, and now it's time for spectral. So at this point, you would actually want to spectral each one of these veins. So you would put your spectral cursor in here, assess it with no augment, no Valsalva, just look for phasicity of flow. And then once you've documented that, you can have your, you would take the image and then you would have your patient Valsalva, and you would take that image and then you would have them augment and take that image. And you're going to repeat the same thing for all 4 of these vessels. And with that, you can follow them up from the distal up to the mid and then up to the proximal calf where you see them converging or anastomosing to create that tibioperineal trunk. And we'll look at some images here in a second. Now, once they've created that tibioperineal trunk, you're going to look for that. You're going to continue on in long, and you're going to look for that anterior tibial vein to dump in. And you'll want to document that in color and Doppler as well. And once you've documented that coming in, as you progress up the leg, you're going to then be in the popliteal vein. So when you're in the popliteal vein, you are going to, again, evaluate it with B mode long, color, spectral, spectral with augment, spectral with Valsalva. Now here you see, actually I don't have this on here, but so you'll watch that profunda and, or pardon me, you're going to evaluate that popliteal, follow it up in long until you see it jump from the back of the leg more to the side of the leg. At that point, the vein is passing through the adductor canal, and you'll want to put your patient back supine, leg out, so that you can access that inner thigh. And you're going to want to follow the superficial femoral vein up the leg in long with color, and you're going to want to take your spectral with augment and your spectral with Valsalva at the proximal, mid, and distal section of the superficial femoral vein. Once you've followed that superficial femoral all the way up until where it combines or anastomoses with the profunda, then that is going to create the common femoral vein. And when you're at that point, you can actually demonstrate the superficial femoral, the profunda, and the common femoral all in one image. So you would assess this in B mode with color, color with spectral, and your spectral you can take at the superficial femoral for your superficial femoral proximal. You would take it at the common femoral, and you would take it in the profunda. And you would repeat that utilizing your augmentation and Valsalva in each of those 3 components. And at that point, you've really assessed the deep venous system. Now, some protocols may ask that you also image and compress the greater saphenous vein in transverse. And if you do that, it's going to start out as a very small superficial vein right at the anterior ankle level, and it compresses very easily, and you can just track that up the entire leg with compression, evaluating its patency there. You can actually see in this transverse image how this is the common femoral vein. So our profunda and our superficial femoral have just connected to create this common femoral vein, and this is the greater saphenous vein dumping into that. So if your site requests, you can absolutely evaluate that greater saphenous vein, and then all the way from the ankle until it anastomoses with the common femoral. However, because it's considered a superficial vein, many site protocols do not require it, so that would be something I'd consult with your lead tech on, or your radiologist. And ultimately, in a very normal exam, that's how you would proceed. Now, when you're going to do augmentation, what you'll see is you're going to be placing your transducer at a certain point on the leg, say that you're just below the knee, and your transducer is right here, and you're usually going to be squeezing the patient at the ankle. And so when you're scanning here and you're getting normal color flow and you're looking at your spectral, and your spectral should appear phasic because it's just being affected by the patient's breathing. Now, when you squeeze the ankle here, it is going to push blood upward, forcing it toward your transducer. And if there's no clot there, you'll see a large whoosh forward motion when you do that augmentation. Now, if there happens to be a clot here, when you augment, it's going to push blood into that clot, but it's not going to have that forward motion by the time it gets to the transducer. So if we see a very depleted forward motion during augmentation, then that would indicate that there's some sort of clot that is preventing that blood flow from accelerating towards my transducer. Now, if there, as I mentioned earlier, talking about the imaging everything in transverse first, if we have found a clot and you're comfortable going forward with the exam, just doing your color, you would definitely want to leave your augmentation out, because this is where you'd be most likely to dislodge a thrombus. So don't augment if you have known thrombus. Now, as you're scanning the lower extremity, you're going to probably come across some veins that, we don't spend a lot of time looking for on this study or even on our anatomy. And so I want to do just a brief overview of some of those additional veins you might come across, so you have more confidence that you're not confusing one vein for another. So the gastrocnemius vein, or veins, is usually a set of paired veins that drain the gastrocnemius muscle of the calf. And so these are not considered deep veins, and so as they're superficial, they are not typically included in your DVT study. They do anastomose with the popliteal, and so what you will see is, here you see the popliteal vein, and here you see the gastrocnemius veins coming in, and they're going to eventually dive down and anastomose with that popliteal. And here you see the gastrocnemius muscle from which they're originating. Another vein that you may find is the smaller saphenous, or formerly known as the lesser saphenous vein. This is a very small superficial vein, and it courses along the posterior mid-calf and anastomoses with the popliteal typically. Sometimes it does extend, it travels farther superior before anastomosing, and it may actually anastomose with the superior femoral vein or the greater saphenous vein. Another additional vein is the soleal sinus vein. This one is not something that we typically look at in our exam. However, it's a common origin of thrombus. And so the soleal sinus vein is a major storage blood system in the calf, and it communicates with the posterior tibial vein. So sometimes if you have clot forming in the soleal sinus veins, while you may not appreciate that because you can't see them as well, you might see that clot extending into the posterior tibial system. Now, diagnosis of thrombus. So we talked a lot about how we're doing the procedures, but we haven't really talked about what we're actually looking for. And so when we're looking for a thrombus, what we really want to evaluate is complete compression of each and every vein, every centimeter, every 2 to 3 centimeters. And so in evaluating that complete compression, we're really ruling out that there could be thrombus there. So we know that our veins change in size as they fill and as they empty. And as my vein is full, if I compress it, I should be able to completely collapse the anterior wall against the posterior wall, so it nearly disappears. If I'm unable to do that, it could be because there's some sort of clot that I am or am not seeing that's preventing that complete collapse. And so compression is a very useful tool in identifying thrombus. Now realize that as you compress, I said you may or may not see the clot, you just can't get it to compress. That's because some of our clots, depending on the age, are going to have different levels of echogenicity. So an early clot is usually going to be more hypoechoic to almost even anechoic sometimes. or have very low level echoes. Now, as that clot ages, it's going to mature and become much, much more echogenic. So obviously your acute or your most recent clots are going to be the hardest to find. So we're really counting on that lack of compression to initiate our suspicion that there is a clot there. If we're not sure if we're getting good compression, and perhaps our angle isn't right or something else is preventing us from fully collapsing that vein, if you see the neighboring arteries beginning to collapse, then you know that you have adequate pressure for compression of the vein, and then you should be even more suspicious of a DVT in that area. If you turn on long or even in transverse, if you add color flow to this and you see that there's incomplete filling of the lumen or even no filling at all in the lumen, then that would indicate that it's possibly obstructed. The really important thing to do, though, however, is make sure that all of your color gain settings are turned down to the most sensitive levels. You can do that by reducing your scale and increasing your color gain, and sometimes even going to power Doppler. And that will make sure that it's not just a poor settings that's giving you this lack of color, but it would indicate that there is truly obstruction there. And one thing you don't want to do a lot of, but if you do suspect that there is clot or you're not sure, you could augment and see if that would move the blood flow enough that you could determine whether it was clot or not. And I know we just said we're not augmenting in thrombus, but that would be if you're just not able to make the diagnosis, sometimes that can be helpful. Okay, acute versus chronic thrombus, I already just mentioned briefly. So acute thrombus is new, and it's going to be hypoechoic to low-level echoes. And this is because the thrombin has just started forming a thrombin net, and it is not very well attached yet, and it's just starting to coagulate. And so this is these are two examples of an acute DVT, where this one's a little bit more prominent. You can definitely see the change in lumen size. That would also be represented if you were to put blood flow on this. Here you see it in long. It almost looks like you could have just some reverberation or some abnormal echoes or even artifactual echoes in this vein, but upon evaluation in transverse, you could identify that it was truly something attached to the anterior wall and not just artifact. Some other things you might see with an acute thrombus is that they can be poorly attached to the wall, and sometimes they can be almost like flapping in the blood flow. These are kind of frightening because they are much more likely to embolize. They also have kind of a spongy appearance where you can compress them some, but not all the way. And they can cause the vein to look more dilated than other ends or than other portions of the system. Now, chronic clots are kind of going to be the opposite here. So they're going to be definitely more hyperechoic to echogenic, and even can sometimes have a mixed appearance. They're well attached to the vessel wall, so the likelihood of these embolizing is much lower. They're more rigid, so with these you're typically not going to get so much spongy compression where you can partially compress the vessel. It's going to be very rigid and keep that vessel dilated. They can, if you've had this for a long enough time, eventually it'll give up on moving flow through that area and could probably create some collaterals. And in that case, because of the decreased venous pressure in that region, it would go ahead and allow the vein to just sort of collapse around the around the chronic thrombus, as you're kind of seeing here. Here's a vein, perhaps here's the clot within it. This clot's been there a long time, perhaps long enough for some collaterals to bypass the clot. And when that is the case, then the vessel walls will compress will collapse because it no longer is providing a lot of pressure to this area. So why does the body create a thrombus? So we talked about Virchow's triad in how stasis and injury or trauma and hypercoagulability can all be factors in leading to thrombus. So really our body has a very complicated system of developing and creating thrombus, but the idea is usually we're building up thrombus to a certain extent we have enzymes that are going to prevent us from building too much thrombus, and then we have thrombolytic materials that are going to go down and break down that thrombus when the need for a clot is resolved. So if this thrombolytic system gets out of whack, you build up the thrombus or you build up too much thrombus, but you're not breaking it down, and that's when these are going to be issues. So if that thrombolytic system is able to begin breaking down some of the clot, you might see something that looks a little bit like this. It's kind of a complex or mixed echogenicity in the clot. This is probably more of a chronic clot that is starting to necrose or break down. And so this one may or may not be resolved eventually. Other clots are never going to be resolved and will just stay chronic and echogenic for indefinitely. If we don't get a good thrombolytic reaction and break down that clot eventually, they become firm and contract, and that may give you that palpable cord feeling. And also, it might fully obstruct that vein, as we saw in the last slide, or it can just partially obstruct the vein, leaving some lumen left available. So depending on this is going to determine really whether your body has to develop those collaterals or not, and how significant the ongoing symptoms of this would be. Color flow with thrombus. You always want to look for, we already talked about how we evaluate our vein in 2D, transverse, and long, looking for those changes in echogenicity that could indicate clot. And then we looked in transverse with compression to see if the change in size with compression indicates clot. Finally, we want to add color flow to this. So if we added color to the vein, we should see vein moving from the caudal end of the leg towards the head. And so as we do this, we should be able to identify that color. And sometimes if we can't identify that color at all, it could indicate that there's a complete occlusion. If we can indicate some color, but the lumen looks very small in comparison to the vein around it, then it might be incomplete occlusion. Now, if we have clot, we don't augment. However, if we can't decide if we have clot or not, and we really need that help with the color, sometimes a gentle little augment might push enough color through to show us exactly where the lumen lies. Now, if I did not identify any clot, but I'm going about my normal routine and I get up to, say, the popliteal, and I augment my patient at the ankle and I see no large motion when I augment, that would indicate that there's a thrombus in between the point of augmentation and the point that I'm scanning at. Now, if I see a lack of phasicity when I'm evaluating just my general color flow of a vein, that would indicate that there's some sort of obstruction between the abdominal pressure and where I happen to be scanning at. So that would indicate that there's a proximal venous occlusion or thrombus. And that same thing goes with Valsalva. It's changing the pressure gradient that we're expecting to see between the abdomen and the legs. And so that would indicate that there's a clot ahead, whereas a lack of augment would indicate there's a clot behind. Now, sometimes you'll see pulsatile flow in the lower extremity venous exam. So this can be very confusing. The reason that you're often going to see a pulsatile flow is that there's an AV fistula. Now, an AV fistula occurs if it's not at the tip of your mind. It's when we have our arterial system usually breaks down from large arteries to medium arteries to small arteries. Those smaller arteries give rise to the arterioles, and those arterioles eventually give rise to little teeny tiny capillaries. And then it dumps into the venous sides where we have our venules, our small veins, our medium veins, and then of course our large veins. So if there's some sort of abnormal connection and I have an artery dumping right into a vein, skipping that venule or skipping that capillary venule area where all of our blood gas oxygen exchange occurs, and the vein takes out waste. If that doesn't occur, we just go from arterial to venous. If this is occurring in my lower venous system, you can imagine that that pulsatility from my arterial system is not broken down as it goes from smaller and smaller arteries. So I will notice that pulsatility in the venous system as well. So that's our AV fistula, and that's why you would see something that looks maybe a little bit more like this, more pulsatile than expected. Another thing that a pulsatile flow in the lower extremity can be, venous can indicate is right heart problems. And so we know that the ultimate destination of our venous flow from our legs is going to be the right atria. And so if my right atria has hypertension, or I have pulmonary hypertension, which is backing up into my right ventricle, which backs up into my right atria, any of those things is going to provide resistance against the venous blood flow coming towards it. And so we can see some of that pulsatility coming back in the waveform, demonstrating some resistance up ahead. So this could indicate that I have high levels of pressure in my right heart. That's being reflected out into my IVC, all the way down my iliacs, and then ultimately down in my lower extremity. So it's that right heart having increased pressures, and so it's reflecting that its pulsatility back into the venous system. Now, when you have those, it's going to be hard to evaluate for augmentation and Valsalva. Valsalva you should be able to accomplish, augmentation possibly, but phasicity would be difficult, very difficult. And so just be aware that that will limit your ability to assess that. Okay, antegrade and retrograde flow. So if you're watching blood flows, let's say you have your color on or your spectral, and you're actually seeing, maybe on your spectral you see antegrade and retrograde flow. This would indicate that you're having forward motion and then reverse motion. And we know that valves are in place to prevent that from happening. So if we're seeing antegrade and retrograde flow, that would indicate that there's some sort of valve damage. You also might see this a lot with patients that have a lot of varicose veins. Now, occasionally this can occur in a very normal patient just because you're having them respirate, or you're watching them breathe, that's going with their respirations, or Valsalva or augment. So sometimes this can be normal, but if you're seeing it repetitively, it could be indication of valvular incompetence. Okay, now beyond the DVT, there's some thrombus-related issues and some non-thrombus-related issues that we might see in the lower extremity. One is called May-Thurner syndrome. This is when the left common iliac artery compresses, the left common iliac compression by the right common iliac artery. And so that compression of artery to vein will cause stasis in the iliac vein, causing oftentimes a thrombus to develop in that iliac vein. Phlegmasia albidolens. This is extensive iliofemoral DVT, causing marked swelling in the lower extremity with pain, pitting edema, and blanching. It's also called milk leg or white leg because the blood flow is so limited that you're not getting good perfusion to get good skin color in that area. Then phlegmasia caerulea dolens is an extension of the phlegmasia albidolens, but this even causes more massive swelling, more severe pain, and ultimately cyanosis of the limb. Venous outflow is completely obstructed, and it can ultimately result in arterial insufficiency. And when we have arterial insufficiency, our tissues are not getting the perfusion of blood they need and can ultimately necrose and cause venous gangrene. Some other more simple non-vascular findings include cysts and hematomas. A cyst looks like a cyst anywhere else in the body, so well circumscribed anechoic with posterior enhancement. We can also have hematomas that can be a little bit more complex, and they really follow the same rules as a thrombus. They start out as low level echoes, they become more echogenic, and then hopefully as thrombolytics kick in, they're going to start breaking down and turning more complex until hopefully they ultimately turn into a cystic appearing structure as all of the thrombus is broken down and becomes serous fluid. You can also see a lot of interstitial edema where you'll see, collections of fluid between adipose tissue layers and other areas. You can find abscesses. Now, abscesses look like an abscess anywhere else in the body. They'll typically have some internal echoes. They can often contain air. They will be pretty well circumscribed or encased, and you'll see hyperemia or extravascularity around the periphery of the abscess because the body is still trying to address the inflammatory process going on there. So hyperemia, circumscribed, low level echoes to complex, and possibly some air. And then enlarged lymph nodes you can see as well. We'll talk about that in a second. And then tumors. Vascular findings, aside from a DVT, could include arterial aneurysms, pseudoaneurysms, which could be iatrogenic in nature, where maybe an artery was nicked during some sort of procedure, bled out around itself, and then closed itself back up, but that bleeding out area looks like an aneurysm even though it's closed off. Atriovenous fistulas that we just discussed, and then significant arterial disease. Even though we're not focusing on the arteries, we're really following the whole arterial system down because it travels with the veins. And so sometimes you will identify severe disease there. And oftentimes it would not be within your scope to extend the exam into an arterial study, but definitely making notes on that, so they might want to order that study at a later date would be prudent. All right, treatment. So if you do find a DVT, it needs to be treated, the primary treatments are anticoagulation drugs. So heparin and warfarin are still used to varying degrees, along with Lovenox. There's also a lower weight heparin now, and these are often injected into the patient's abdomen. There's also a lot of new oral anticoagulants on the market. You might hear them advertised as Eliquis, Pradaxa, Savaysa, and Xarelto. Other treatments would be gradient elastic stockings, or really kind of compression stockings to keep, to actually kind of assist the muscles in being a pump and keep those veins from becoming too static. And then there can also be thrombolytic agents injected that can break down the clot, or thrombectomies where the whole thrombus is removed surgically. Now, a lot of the information you're finding from your DVT, as well as the patient's condition and history, are going to determine what kind of treatment they are prescribed. Well, thank you so much. We finally made it to our summary. So in real brief summary, Virchow's triad describes the circumstances that increase risk for DVT. We know that that Virchow's triad includes stasis, and increased anticoagulation, and trauma or injury. Wells criteria is a criteria physicians can use evaluating information from Virchow's triad, as well as D-dimer and other techniques, to come up with a criteria, and over a certain value, a physician would use Wells criteria to probably take the next step in evaluation, whereas if they're coming up with a number below a CIFR value, they may just watch and see. DVT can place a patient at risk for life-threatening PE, and so that's why we need to take this very seriously. With early detection and treatment, these risks are reduced. Identifying a DVT requires a sonographer to be knowledgeable about venous anatomy, physiology, and relationships to other systems such as the cardiac system, as we talked about just a moment ago when we're seeing that pulsatility in the venous system. Utilizing a thorough standard protocol optimizes a sonographer's ability to detect DVT and other lower extremity abnormalities. So I hope in some way some of this content will help you feel more confident in your scanning, and maybe hone your protocol to something that you feel really comfortable with. And if you need anything, please be sure to reach out and let us all know. Have a great week.